I want to tell you about a conversation I had that changed the way I practice medicine. A colleague of mine, an internist with 30 years of experience, called me one evening about a mutual patient, a 74-year-old man, retired engineer. He had come in complaining of increasing fatigue, mild shortness of breath on exertion, and an occasional dizziness when standing up. Three symptoms that, individually, could mean almost anything in a man his age. But my colleague had noticed something. When he laid out every medication this man was taking, something he admitted he had not done comprehensively in over 2 years of treating him, he counted 11 different prescriptions from 4 different physicians, 4 different doctors, none of whom had a complete picture of what the others were prescribing. 2 of those 11 medications were directly and measurably harming this man's heart, not as rare side effects, not as unusual reactions, as documented, predictable, physiologically inevitable consequences of giving those specific drugs to a man of his age and cardiovascular profile. Consequences that every prescribing physician should have anticipated and did not. His fatigue was not aging. His shortness of breath was not deconditioning. His dizziness was not benign. His heart was being chemically undermined by medications prescribed by well-meaning doctors who simply had not looked at the whole picture. When we adjusted his regimen, 2 medications stopped and 1 dose significantly reduced. His symptoms had improved within 3 weeks. He came back into my office a month later and told me he felt 10 years younger. He had assumed that feeling worse every year was simply what getting older meant. It was not. It was what being on the wrong medications meant. My name is Dr. Caroline Adeyemi. I am an interventional cardiologist. I have been practicing for 23 years, and I have sat across from more patients than I can count who were being harmed by medications they had been told were helping them. Not because their doctors were careless, but because the relationship between commonly prescribed drugs and the aging cardiovascular system is more complex, more dangerous, and more poorly communicated to patients than almost any other topic in medicine. Today I am going to tell you about 5 categories of popular medications that carry serious, documented, and frequently under-discussed risks for the heart in people over 60. I am going to tell you the mechanism by which each one causes harm, what the research says about the magnitude of that harm, and what questions you need to ask your doctor if you are currently taking any of them. I need to say something clearly before we begin. Nothing I share today should cause you to stop taking any medication without speaking to your physician first. Some of these medications, despite their risks, are genuinely necessary for certain patients. Stopping them abruptly can be more dangerous than continuing them. The goal of this conversation is not to frighten you into throwing away your pill bottles. The goal is to make you informed enough to have a real, specific, productive conversation with your doctor that you may not have had yet. That conversation could change your life. It changed the engineers. Let me also tell you something about aging and medication that most patients never hear explained. The way your body processes medication changes profoundly after 60. Your liver, which metabolizes most drugs, functions at roughly 40% of its capacity in a healthy 75-year-old compared to a healthy 30-year-old. Your kidneys, which clear most drugs from the system, lose approximately 1% of their filtering function every year after the age of 40. By 70, the average person has lost 30% of their kidney clearance capacity. Your body fat percentage increases with age, changing how fat-soluble drugs are distributed and stored in your tissues. And the number of drug receptors in your heart and blood vessels changes, making those organs more sensitive to the same dose that caused no problems a decade earlier. What this means practically is that a medication prescribed at a certain dose when you were 55 may be producing blood levels 2 to 3 times higher than intended by the time you are 72. Even if you are taking exactly the same dose as always, the prescription has not changed. Your body has. And that difference can turn a safe medication into a dangerous one without a single warning sign until something goes wrong. This is called pharmacokinetic aging. It is one of the most clinically important concepts in geriatric medicine, and it is almost never explained to patients. Now here are the 5 medications. Medication number 1, NSAIDs, non-steroidal anti-inflammatory drugs. Ibuprofen, naproxen, diclofenac, celecoxib. These drugs are so common, so available without prescription, so woven into the daily lives of older adults managing arthritis, back pain, and joint inflammation that most people do not think of them as medications with serious cardiac implications. They think of them as painkillers, routine, safe, the thing you reach for when something hurts. For the heart of an adult over 60, this perception is genuinely dangerous. Here is the mechanism. NSAIDs work by blocking enzymes called COX-1 and COX-2. These enzymes produce prostaglandins, which are signaling molecules involved in inflammation and pain. When you block prostaglandins, pain and inflammation decrease. That is the benefit. But prostaglandins also play a critical role in maintaining the balance between substances that cause blood clotting and substances that prevent it. They regulate sodium and water excretion by the kidneys, and they help maintain the tone and flexibility of blood vessel walls. When NSAIDs suppress prostaglandin activity throughout the body, they simultaneously cause sodium and water retention, raising blood volume and therefore blood pressure. They shift the clotting balance toward increased thrombosis risk, and they reduce the production of prostacyclin, a compound that normally protects arterial walls from inflammation and plaque formation. The cardiovascular consequences of these combined effects are not small. A comprehensive meta-analysis, published in the British Medical Journal, analyzed data from over 350,000 patients across 754 randomized trials. The conclusion was unambiguous. Regular NSAID use was associated with a significantly increased risk of heart attack, stroke, heart failure, and cardiovascular death. Specifically, diclofenac increased the risk of major cardiovascular events by approximately 40% compared to placebo. Ibuprofen increased that risk by approximately 35%. Even celecoxib, the COX-2 selective inhibitor that was originally developed partly to reduce cardiovascular risk compared to traditional NSAIDs, showed meaningful elevation of cardiac event risk at commonly used doses. For a person over 60 with existing cardiovascular conditions, hypertension, or kidney disease, these risks are compounded by the physiological changes of aging I described earlier. The same dose of ibuprofen that mildly elevated blood pressure in a 50-year-old may cause significant hypertensive response in a 70-year-old whose kidneys are clearing the drug more slowly. A particularly dangerous pattern I see regularly in clinical practice is the patient who takes ibuprofen or naproxen daily for chronic arthritis pain, has been prescribed a blood pressure medication and cannot understand why their blood pressure remains difficult to control despite taking their antihypertensive faithfully. The NSAID is directly counteracting the blood pressure medication, two drugs working against each other, and nobody has connected the dots. The questions to ask your doctor if you take NSAIDs regularly are these. Given my age and cardiovascular profile, what is my specific risk from continued NSAID use? And what are the alternatives for my pain management, including topical diclofenac gel, which delivers anti-inflammatory effect locally with dramatically lower systemic absorption, acetaminophen for mild to moderate pain, or physical therapy, and other non-pharmacological approaches. Medication number 2, certain antibiotics, fluoroquinolones and azithromycin. This one surprises people profoundly. Antibiotics are prescribed for infections. They are supposed to help you get better. The idea that common antibiotics could harm your heart feels counterintuitive, almost absurd. But the cardiac risks associated with two commonly prescribed antibiotic classes are documented, serious, and specific enough that the FDA has issued formal warnings about both of them. Fluoroquinolones, which include ciprofloxacin, levofloxacin, and moxifloxacin, are among the most widely prescribed antibiotics in medicine. They are used for urinary tract infections, respiratory infections, and a wide range of bacterial conditions. They are also, and this is the mechanism patients need to understand, potent blockers of specific potassium channels in heart muscle cells. Potassium channels in cardiac cells control the electrical repolarization of the heart after each beat. When these channels are blocked, the repolarization takes longer. On an electrocardiogram, this appears as a prolongation of something called the QT interval. When the QT interval is prolonged beyond a certain threshold, the heart becomes vulnerable to a potentially fatal arrhythmia called torsades de pointes, a specific type of ventricular tachycardia that can degenerate into ventricular fibrillation and sudden cardiac death. In young healthy adults with normal baseline QT intervals and no other risk factors, fluoroquinolone-induced QT prolongation is rarely enough to cause a clinical event. But in adults over 60, the risk profile is categorically different. Aging itself is associated with subtle QT interval prolongation at baseline. Many common medications taken by older adults, including certain antidepressants, antifungals, antihistamines, and other antibiotics, also prolong the QT interval. When a fluoroquinolone is added to a medication regimen that already contains QT prolonging drugs, the combined effect can push the QT interval into genuinely dangerous territory. And the kidneys of older patients clear these antibiotics more slowly, producing higher and more prolonged blood levels than the same dose would produce in a younger patient. The FDA's black box warning on fluoroquinolones, the most serious warning category available, specifically mentions the risk of QT prolongation, tendon rupture, and other serious adverse effects, with explicit notation that risk is higher in older patients. Azithromycin, commonly known by the brand name Zithromax and frequently prescribed as a 5-day Z-Pack for respiratory infections, carries a similar QT prolongation risk. A study published in the New England Journal of Medicine found that patients taking azithromycin had a significantly increased risk of cardiovascular death compared to patients taking amoxicillin for similar infections. The increased risk was most pronounced in patients with existing cardiovascular conditions, which describes a very large proportion of adults over 60. The question to ask your doctor when an antibiotic is prescribed is specific. Does this antibiotic prolong the QT interval? And given the other medications I am taking, is there an alternative antibiotic that does not carry this cardiac risk for my profile? For urinary tract infections in older women, for example, nitrofurantoin and trimethoprim sulfamethoxazole are frequently effective alternatives to fluoroquinolones that do not carry the same cardiac mechanism of harm. Simply knowing to ask the question opens the door to a safer choice. Medication number 3. Certain antidepressants, tricyclics and high-dose SSRIs. Depression in older adults is significantly undertreated, and antidepressant medications have genuinely transformed quality of life for millions of people. I want to be careful here not to contribute to the already serious problem of antidepressant stigma or create anxiety that prevents people from getting mental health treatment they need. But specific classes of antidepressants carry cardiac risks in older adults that are serious enough to warrant a direct conversation with your prescribing physician if you are over 60 and currently taking them. Tricyclic antidepressants, including amitriptyline, nortriptyline, imipramine, and doxepin, are older medications that remain commonly prescribed for depression, chronic pain, insomnia, and neuropathy. They are inexpensive, widely available, and familiar to many physicians. They are also, for adults over 60, with any degree of cardiovascular compromise, among the most cardiotoxic medications in common clinical use. Tricyclics work primarily by blocking the reuptake of norepinephrine and serotonin in the brain, but they are pharmacologically promiscuous drugs, meaning they affect many different receptor systems simultaneously. They block sodium channels in heart muscle cells, slowing electrical conduction. They prolong the QT interval through potassium channel blockade. They have significant anticholinergic effects that accelerate heart rate, and they cause orthostatic hypotension, a sudden drop in blood pressure upon standing, that in older adults frequently leads to falls, fractures, and in patients with underlying coronary artery disease, reduced blood flow to the heart muscle during the hypotensive episode. In patients over 65 with existing heart disease, tricyclic antidepressants are associated with significantly elevated risk of cardiac arrhythmias and sudden cardiac death. The American Geriatric Society Beers criteria, the authoritative clinical guideline for medication safety in older adults, lists tricyclic antidepressants as medications to avoid in older patients, specifically because of their cardiac and neurological risk profile. The situation with SSRIs, selective serotonin reuptake inhibitors, is more nuanced. At standard therapeutic doses, most SSRIs are considerably safer for the heart than tricyclics, but at higher doses, several SSRIs, particularly citalopram and escitalopram, produce clinically significant QT prolongation. The FDA has issued specific dose limitation warnings for citalopram in patients over 60, reducing the maximum recommended dose from 40 milligrams to 20 milligrams because of this cardiac risk. Many patients and some physicians are not aware that the dose considered safe in younger adults is considered excessive in older ones. If you are currently taking an antidepressant, particularly a tricyclic, ask your doctor specifically. Is this medication on the Beers criteria list for older adults? What is my baseline QT interval on an ECG? And are there alternatives with a safer cardiac profile for someone my age? Medication number 4. Proton pump inhibitors at high doses. PPIs, proton pump inhibitors, omeprazole, pantoprazole, esomeprazole, lansoprazole, are among the most prescribed medications in the world. They reduce stomach acid production and are used for acid reflux, gastroesophageal reflux disease, peptic ulcers, and as protective cover for patients taking NSAIDs or aspirin. They are also widely available over the counter, inexpensive, and perceived by most patients and many physicians as essentially harmless. Take one every morning. Keep the stomach comfortable. No real downside. The cardiac implications of long-term PPI use in older adults are more significant than this perception suggests. The primary mechanism of concern involves magnesium. PPIs reduce the absorption of dietary magnesium from the gut through a mechanism involving the magnesium transport proteins in intestinal cells. Over months and years of continuous use, many patients on PPIs develop chronic hypomagnesemia, meaning low magnesium levels in the blood and tissues. Magnesium is not a minor nutritional footnote. It is essential to the electrical stability of heart muscle cells. It is a natural calcium channel blocker, helping regulate the flow of calcium into cardiac cells that drives each heartbeat. It is critical for maintaining normal heart rhythm. When magnesium levels fall below optimal range, the heart becomes significantly more prone to arrhythmias, particularly atrial fibrillation, ventricular ectopy, and in severe cases, potentially fatal rhythm disturbances. A study published in the American Journal of Medicine found that long-term PPI users had significantly lower serum magnesium levels than matched controls not taking PPIs, and that the degree of magnesium depletion correlated with duration of use. The FDA issued a drug safety communication specifically warning that PPIs can cause low serum magnesium levels if taken for prolonged periods. Beyond magnesium, long-term PPI use has been associated in multiple large epidemiological studies with increased risk of kidney disease, which independently elevates cardiovascular risk, and with increased risk of Clostridium difficile infections causing severe gastrointestinal inflammation. There is also emerging research suggesting that PPIs may impair the function of nitric oxide synthase in blood vessel walls, the same enzyme that produces the vasodilating nitric oxide we discussed in the context of dietary nitrates. If confirmed, this would represent a direct mechanism by which long-term PPI use could impair arterial flexibility and contribute to hypertension. The question for your doctor if you have been on a PPI for more than a year is this: do I still need this medication at this dose? Many patients are continued on PPIs indefinitely after the original indication. An ulcer, a course of NSAIDs, a bout of esophagitis has resolved. And have my magnesium levels been checked recently? Medication number 5. Certain antihistamines, first-generation H1 blockers. This is perhaps the most surprising entry on this list, because the medications in this category are available in every pharmacy without a prescription, marketed primarily for allergies and sleep, and consumed by millions of older adults with complete confidence in their safety. Diphenhydramine, the active ingredient in Benadryl, and in virtually every over-the-counter sleep aid including Zed's Quill, Unisom sleep tabs, Simply Sleep, and countless generic formulations, is a first-generation antihistamine. It is also one of the most potently anticholinergic compounds in common use. And for the aging heart, anticholinergic activity is a serious and underappreciated danger. Anticholinergic drugs block muscarinic receptors throughout the body. In the heart, muscarinic receptors are part of the parasympathetic nervous system, which normally acts as a brake on heart rate. When these receptors are blocked, the heart rate accelerates, sometimes dramatically. In a young person with a healthy cardiovascular system, this acceleration is uncomfortable but manageable. In an older adult with underlying coronary artery disease, even moderate heart rate elevation significantly increases oxygen demand by the heart muscle. When oxygen demand exceeds what narrowed coronary arteries can supply, the result is ischemia, meaning heart muscle being starved of oxygen. Ischemia causes chest pain. Sustained ischemia causes heart attack. Diphenhydramine additionally prolongs the QT interval through its antihistamine activity, adding an arrhythmia risk on top of the heart rate acceleration risk. The American Geriatric Society Beers criteria lists first-generation antihistamines, including diphenhydramine, as medications to avoid in older adults, specifically because of their cardiac and cognitive risks. The cognitive effects, excessive sedation, confusion, increased fall risk, and contribution to delirium, are generally better known than the cardiac ones, but both are serious. And here is the clinical pattern that troubles me most. An older patient with insomnia takes diphenhydramine nightly because it is sold specifically for sleep. It is available without a prescription, and nobody has told them it is on the high-risk list for their age group. Their heart rate runs slightly elevated every night. Their QT interval is marginally prolonged. Their doctor, reviewing their resting ECG at an annual visit, sees findings within normal limits and does not connect them to the antihistamine because nobody thought to mention it. If you take any over-the-counter sleep aid or allergy medication regularly, check the active ingredient for diphenhydramine or any other first-generation antihistamine. Then have a direct conversation with your doctor about safer alternatives. For allergies, second-generation antihistamines, including loratadine and cetirizine, are equally effective without the cardiac and anticholinergic burden. For sleep, the conversation with your doctor about behavioral approaches, melatonin at appropriate doses, or prescription alternatives with better safety profiles for older adults is a conversation worth having. Let me bring all of this together with something concrete. The 5 categories of medications we discussed today: NSAIDs, certain antibiotics, certain antidepressants, proton pump inhibitors, and first-generation antihistamines share a common thread. Each one is commonly prescribed or consumed, perceived as relatively safe, and carries cardiac risks in adults over 60 that are mechanistically specific, clinically documented, and frequently under-discussed between doctors and patients. None of this means you should stop taking any medication without guidance. What it means is that you are entitled to a comprehensive medication review that includes an honest conversation about cardiac risk for your specific age and health profile. There is a specific request I want you to make at your next appointment. Ask your doctor or pharmacist for what is called a medication reconciliation, a complete review of every prescription and over-the-counter medication you take, cross-reference for cardiac interactions and appropriateness for your age. Many hospital systems and pharmacy chains offer this service specifically. The American Geriatric Society Beers Criteria, which I have referenced several times today, is a publicly available document that lists medications considered high risk for older adults. You can look it up by name. You can bring it to your appointment. You can ask your doctor directly. Is anything I am taking on this list? That one question, asked clearly and specifically, is one of the most powerful things you can do for your cardiovascular health. It costs nothing. It takes 30 seconds. And it has the potential to identify a risk that has been quietly present in your medicine cabinet for years. The engineer who felt 10 years younger after his medication review did not need a new procedure. He did not need a surgical intervention. He needed someone to look at the whole picture and ask the questions that should have been asked years earlier. You deserve that same complete picture. Tell me in the comments, are you currently taking any of the medications we discussed today? And has your doctor ever done a comprehensive cardiac review of your full medication list? Share this with someone you love who takes multiple medications. In a world where the average American over 65 takes more than 6 prescription drugs daily, this conversation is not optional. It is essential. Take care of your heart. It is working hard enough already.